Are we supposed to sit very serious and silent, or can we smile also?
We are live.
Hello, everybody. Greetings from Endocrine Society of India and SAFES. Today, we are actually going for the third session of our Facebook Live interaction. The topic for today is making sense of the numbers in diabetes. So as you know, diabetes is a chronic disease, a non-communicable disease. It's actually a pandemic. And in the COVID context, we know that the more the awareness is created towards the World Diabetic Day, which is on November 14th, which is why the ESI, along with the SAFES, South Asian Federation of Endocrine Societies, have gone together and collaborated in this venture. Greetings, myself, Dr. Mohan Shenoy. I am a consultant endocrinologist in Sri Gokulam Medical College, Trivandrum. So I am the host of the day. So I will be taking you through two panel discussions. We have got expert endocrinologists all over from our region, Southeast Asian region. So the first panel is regarding the scores and goals in diabetes. As you know, yesterday we had discussion on the myths regarding type 1 and type 2 diabetes. And in the first day, we had life is beautiful with diabetes. So diabetes is not at all a problem when you deal with it in the right manner. So the first panelist we have to introduce. So the first panel will be moderated by Dr. Chaminda Garusinghe. Sir is affiliated to the Endocrine Society of Sri Lanka. He has done his degrees from University of Penadia and trained in National Hospital of Sri Lanka. He has got overseas trained from St. Bartholomew's College and St. George Hospital, London. He has authored several publications in peer-reviewed scientific journals. His research interests include diabetes, endocrinology, and metabolism. Welcome, sir, with the folded hands.
Thank you. Thank you.
The next panelist would be Dr. Ganesh HK. Sir is a close colleague and he's done his endocrinology from St. GS Medical College and KEM from Mumbai. He has been distinguished with many awards, which include A.R. Seth Medal for the best research paper from the Endocrine Society of India. He has trained in diabetes food care from Amrita Institute, Kochi, as well as got several publications, including 11 international and 15 national publications. He is having spearheaded many programs in diabetic awareness across country as well as regional. Welcome, sir.
Thank you. Thank you.
To complete, so second panelist for the day in the first panel discussion would be Dr. Deepak Mal. He is from our neighboring country, Nepal. He is affiliated to the National Academy of Medical Science and Beer Hospital, Kathmandu. He is an endocrinologist and diabetes specialist working in this area with authors of many publications in peer-reviewed national and international journals. He has got a good poster presented in the 11th Asia Pacific Diabetes Conference and Expo in Brisbane, Australia. So he's a researcher in diabetes and metabolism. So welcome, sir, to the discussion.
Thank you, Dr. Mohan. Thank you so much.
The third panelist in the discussion would be Dr. Shaila Sheikh. We all know ma'am. Ma'am is a executive member of the ESI. She has been honored with the Top Dogs Mumbai by the Times of India Group 2017 to 2020 consecutive years. She has got the first prize in clinical poster and presentation ESICon 2001 in Mumbai, as well as the lead author of Management of Diabetes in the Hajj. So she has been co-author of many guidelines like risk stratification during Ramadan, as well as various real-world studies in Dia Ramadan. So she is focused on obesity and prevention, osteoporosis, and structured diabetes care. She is affiliated to the Prince Ali Khan and Saifi Hospital, Mumbai. Welcome, madam.
Thanks, Mohan.
So I just hand it over to the moderator, Dr. Chaminda. Over to you, sir.
Thank you, Mohan. Thank you very much. First of all, on behalf of the Endocrine Society and Sri Lanka College of Endocrinologists, I sincerely thank you all for involving us, because I believe that we all should face this epidemic of diabetes together, because there are so many things in common, lifestyles, religions, and so on. So we have very vibrant panel of experts today, Dr. Ganesh, Dr. Deepak, and Dr. Shaila. I have a set of questions, especially because when it comes to diabetes, most of the patients, even the ones that I saw a while ago, they have blood sugar of 300, 400, but they're fine. And they are not worried. So they are just at home and they just carry on with their life. And one fine day, they enter this room with some complications, neuropathy or cardiac problems, kidney disease, and so on. So as you all know, the diabetes is a very, very asymptomatic disease. Even if your blood sugar is 200, 300, sometimes even 400, you will be walking on the road without, carrying anything about diabetes or yourself or about the others. So that's the nature of diabetes. So how do we keep one under control when it comes to diabetic parameters? So it all depends on a set of laboratory investigations. So we always tend to do few tests just to see the sugar level because of the nature of this disease. So I have a couple of questions from each panelist. So let me pick up Dr. Ganesh first from Mangalore. Dr. Ganesh, I just have this question. So when you have diabetes, as I said, most of them are asymptomatic. So what should people monitor? Like now there are so many tests, lipid profile, sugar, and various types of sugar, fasting, postprandial blood sugar, and the blood test and kidney function. So many tests are there. So let's take a typical type 2 middle-aged diabetic person. So what are the tests that the person or the parameters that the person should be monitoring?
Yes, sir. Thank you, Chaminda, sir, for that question. So actually, all diabetic patients should be testing their blood tests routinely, frequently, so that they can avoid the long-term complications. As you rightly said, sir, if they are not monitoring, ultimately they will end up with the long-term complications, which are most of them are irreversible. So to prevent that irreversible thing from happening, they have to monitor their parameters regularly and keep them under check. And if it is not under control, then go to the doctor and modify their medications so that it comes under control. And so that the ultimate aim is to prevent the long-term complications. So the most important parameter is sugar levels, the fasting sugar, postprandial sugar, that is 2 hours after food. These two sugars are the most important things. Once in 3 months, at least they have to check the sugars. If the patient is reasonably under control, if the person is reasonably under control, at least once in 3 months, they have to check the fasting and postprandial sugars. If they are not under good control, probably they have to do it a little more frequently. Once in a month also we'll have to do, especially if the patient is on insulin. Once in 3 months might not be sufficient. And one more very important parameter is the last 3 months average control, that is called glycosylated hemoglobin or HbA1c. So that gives us the average of last 3 months. That is actually very, very useful test because that particular day's sugar might be due to the food intake on that particular day. So it might be very good if they are fasting in the last 2 days, if they are meticulously doing the diet, it might come very good. So that is the reason we have to ask that it's HbA1c, glycosylated hemoglobin, they have to do at least once in 3 months. In addition to this, there are, as you rightly said, sir, we have to monitor lipid profile once in at least 6 months, or if not possible, at least once in a year, so that we can, if there is a dyslipidemia, they can do diet modification, exercise, as well as they can go for some medications which can reduce the cholesterol levels. And other very important parameter is serum creatinine, the kidney function, which they have to do once in a year. And one more test is urine test, urine microalbumin or urine protein by creatinine ratio, which will tell us regarding the filtrating the filtratory capacity of the kidney and whether there is a proteinuria. If it is there, so that we can give some drugs to reduce the proteinuria, and also the blood sugar control has to be a little more better. One more important test is retinal examination or eye fundus examination to screen for retinopathy. So every year, at least once in a year, they have to undergo fundus examination to rule out retinopathy. These are the tests we can do as a monitoring purpose. Even in asymptomatic individuals, we have to do all these things, sir.
Do you recommend, now this is the question that most of our diabetic patients ask. So when they are diagnosed with diabetes in the first few months, they are very, very, very committed and keen, and so that all, and they all buy blood sugar meters and they check the blood sugar all the time and then come back to you with very confusing readings. Now, is it recommended that the type 2 diabetic patients who is on oral hypoglycemic drugs, to be checking the blood sugar all the time, or what is the recommendation? How frequent should they check? I'm referring to CBS, capillary blood sugar.
Yes, sir. The type 2 diabetes, there is no, they don't have to do very frequently, especially in the early part of the diabetes. But whatever said and done, practically, if they are doing it at least in 15 days or once in a month, they'll get an idea. Otherwise, what will they do? Most of the times, even if they tell to do once in 3 months, they won't do, and they will come after 1 year or 2 years. That is the usual scenario. They come very late because of the various reasons. They are busy, tied up with their daily schedules, so they might not come. So if they have that capillary glucose monitor at home, at least they'll do, and if the sugars are climbing like 200, 250, they will at least come to know, and either they'll do better lifestyle modification or take medications as advised by the doctor. So I feel, sir, if the patient is having capillary glucose monitor, which is always good, and better to monitor at least once a month, sir.
That's correct. Yeah, that is something that a lot of our patients confuse, because if you are on oral hypoglycemic and if your control is not so bad, then you don't need to be monitoring every day. But on the other hand, if you are on multiple dose insulin, and if you are a hypoglycemic prone person, and then it is fine. As you correctly said, it is always fine, better to have a blood sugar meter at home for any diabetics. But we will not recommend to someone on oral hypoglycemic to be checking all the time and get distressed about these minor fluctuations of the blood sugar. Right. Yes, thank you. Thank you. Now, my second question goes to Dr. Deepak Mall from Nepal. So now we talk about fasting and postprandial blood sugar. So what are the targets we should maintain in these patients? Now, given the fact that it can also vary, just give us a brief understanding what are the target range that or the target you should maintain.
Thank you, sir, for the lovely question, and I think this is the most important question when we sit in our clinic. Everybody asks us, sir, what can I do to make my sugar level very, very low? And I think we must be answering our patients in such a way that they must know what is fasting level. Sometimes, when the patient comes to you and they might be telling you that, doctor, I haven't eaten anything for the last 18 hours, 24 hours. At that time, obviously, the blood sugar will be low. So whenever we are trying to explain our patient, then I think we must be explaining them what is fasting. So fasting is a state of not eating any kind of carbohydrate or any food for at least 8 hours or within 16 hours. But there are some patients that they will come after more than 16 hours. And we have to explain them what is PP, what is postprandial. Postprandial, sometimes, whenever the patients comes to, they will eat very, very little and just come to you. They will not, otherwise, on the some other hand, they will just come, they will eat a lot of food. They will eat biryani, they will eat this kind of jeri puri and all these things and come to you. They want to test their level. So we have to explain them, please come to us after the normal meal and come to us after 2 hours. So what we can do, normal level of blood sugar can be from 70 to 100 in a fasting. If you are trying to rule out something like pre-diabetes, then it must be 100 to 125. And if the fasting level is more than 126, then we call it diabetes. And if the level is PP level, postprandial level, then normal postprandial level, we can call it less than 140. If it is pre-diabetes, we can call it 140 to 199. If it is diabetes, then it must be after more than 200. So these levels are there, but as you already told, we must be very cautious with our old age patients, with those patients who are suffering from CKD, CLD, and all these things. At this time, the fasting must not be kept very, very low because the risk of hypoglycemia is always there. And at the same time, we have to, and those patients who are taking a lot of alcohol, we must ask them not to keep their blood sugar very, very low. So there are always our life is all full of numbers, mobile number, targets, date of birth, date of enlistment, and all these things. And we as a physicians are always dealing with this kind of targets in our life. So targets are there, but we must be very, very flexible with our patients. We keep these targets so that we will not be encountering any kind of complications with our patient, like Dr. Ganesh already told, nephrotic syndrome, CKD, CLD, microvascular complication must be delayed in our patients. So I think these are the targets that we need to keep in our mind while we're
One of the other thing is now patients tend to check postprandial blood sugar more often than they should be checking it. Now, I have noticed some of the patients, they check the postprandial and then they check the postprandial and they get scared when the postprandial is 140, 150. So if someone to check the blood sugar with the glucometer, what is the best blood sugar you recommend for a reasonably controlled patient? Is it whether it is fasting, postprandial, or pre-dinner, pre-lunch, or what do you think will be the most?
Yeah, that would be. I think we must be always in this also. We must be very fluctuating that we can keep the blood sugar level from 70 to 180. 180. If the patient is there with a report with 160 also, a random blood sugar with 160 also, that might be a very good result for us. But at the same time, we must ask them. There are so many things that our patients they are not enjoying their life. They are not eating anything. They are not going for any kind of party and all these things. So I think from a blood sugar level, fasting 170 to PP 180, these are the desirable target that we need to keep.
Yeah, yes, exactly. So if they check any blood sugar, the fasting should be the number one to check now, because that is the one that will reflect the most of the the situation in the patients. But it varies. We'll come to that those who have good control, closer HbA1c closer to 7, they will. Their postprandial may be very much indicative of poor control than fasting. Whereas if HbA1c is very high, then your fasting contributes more to your HbA1c. There's something like that, but we should not. I generally don't confuse patients with this because they will take this in the wrong meaning. Yes, now we have Dr. Sheila Sheikh. Can I ask her, what is HbA1c and what is the target HbA1c?
Good evening, Dr. Chaminda. And first of all, hi to everybody out over there who's logged in and who's with us today midweek. So thanks for logging in, first of all. Dr. Chaminda, I think a very, very pertinent question, because, though we are all the time talking about reaching targets, often our patients are very hesitant about doing an HbA1c. They're very happy with their fasting and PPs, as Dr. Deepak is saying. They'll be very happy doing a fasting and PP. And the moment you say HbA1c, it's like, why do I need an HbA1c, ma'am? Just find out from what's happening from these numbers which I've got to you. I think it's very important that we convey to everybody out there that your fasting PP, and as Dr. Deepak said, that your fasting PP is influenced by so many things, is like maybe a single shot in a movie. To know the entire 3-hour movie, you need an HbA1c. If I put it, we belong to a country which is Bollywood, and so yeah. I think if I put it that way, a 3 hours movie is something like a 3 months a reflection of your HbA1c. So the entire story is conveyed by HbA1c. And you would ask me, why is the story conveyed by an HbA1c? Is a fasting PP not good enough? I think both Ganesh and Dr. Deepak and Dr. Chaminda have been telling us that an HbA1c is very, very important for us, because an HbA1c actually tells you at what kind of risk you are finally of micro and macrovascular complications. We've been talking about numbers out here. And when you are talking about numbers, the way the HbA1c gives you this number is because it attaches to your RBCs. Now that RBC's life in your body is for 3 months. And that's the reason this RBC, which is circulating in your body for 3 months, gives all of us who are looking after you a better idea about how your sugars are. And if you keep that as close to target as possible, and mind you, this target is very, very individual. Please don't compare. Ma'am, mere baaju wale ka number is 7. He's doing better. My number is 7.2. So maybe I'm not doing that well. This is not maths. This is biology. So you often have this. I face this, especially if you have family. It's almost like a competition. Oh my God, he did better than me, which is not very, happening. Individual targets, like for example, as Dr. Deepak said, you have a kidney issue. You are going to have an HbA1c. Maybe Ganesh will decide to have an HbA1c of 8 in you, and he'll be very happy with that HbA1c of 8. You come to Dr. Chaminda with a pregnancy, and Dr. Chaminda will go ballistic if your HbA1c is not lower than 7. He'll say 6.5, 6.4. So these are individual targets. Talk to your doctor, have a conversation, understand why your doctor is so insistent about an HbA1c, and please do it so that you are at goal, you are at a target, and none of us have to deal with all those complications that we are seeing. Thank you very much.
Yeah, HbA1c is it's a very valid surrogate marker of our glycemic burden in the body, as you correctly said. So if you're, it's like a 3-hour film. I think nowadays the films are not 3 hours; they are, I think, shorter than 3 hours. I don't know.
So HbA1c is skewed. So 2 hours representation also is okay. 2 months.
Okay. Yeah. So they say you have to repeat it 3 months if your control is not good, but if you are very good, then 6 months should be enough. And it changes according to various other health conditions. Now, recently, 2-3 days ago, I was asked to see a patient who has just had a bypass surgery, and the blood sugar was running at 200, 300. Now, I looked at the doctor told me, doctor, don't worry, his HbA1c is 5.5. So I was wondering why. So what has happened here? There actually, you all know. Now, because the patient has received blood transfusion at the time of bypass surgery. So what the HbA1c shown there is not patient's HbA1c, some young adult's HbA1c who has given blood for the patient. So likewise, now there are various factors where HbA1c can be slightly up and down, anemia and hemolytic conditions, pregnancy, and so on. So, but by a large, HbA1c is the one that we believe in. That's what we want to keep at the target level. Now, yes, now the next question I have to ask again from Dr. Ganesh. Dr. Ganesh, does glycemic targets vary according to the clinical condition? So do you apply one suit for all, or you have any, how do you decide what is the target for each and every patient?
Yes, sir. We actually, we have to tailor make it. Just like Dr. Shela was just telling, we can't keep HbA1c target for each and every individual the same. For example, if a very young individual comes, long life expectancy, very young, 30, 40 years, we have to control it very, very strictly. His HbA1c should be below 6.5. And now, previously, it was difficult to achieve at that HbA1c. Now there are so many medications. They can do diet, exercise. They can have a lot of medications which do not produce hypoglycemia. With the availability of such medications, it is possible to bring down the HbA1c to less than 6.5 without hypoglycemia. So young individuals, no comorbidities, long life expectancy, in such people, we have to intensively control the HbA1c, better to keep it below 6.5. So let us say another person who is having other comorbidities, underwent CABG just now like your patient, and who had other comorbidities, other problems in other complications, then we can relax the target. We can keep the HbA1c between 7 to 8 also. But even that person, if the person who has undergone CABG, otherwise he is doing very, very well, we can control intensively also. But in patient with the CKD or chronic liver disease or chronic kidney disease, where they are prone for hypoglycemias, and we can't give many of the medications also, and we have to resort to insulin in many such patients, in such individuals, the hypoglycemia is risky and can be very tricky. So that is the reason in such individuals, we have to relax the target. Up to 8% HbA1c is fine. So in another condition like comorbidities like malignancies, the patient is having CLN or which is very bad, the prognosis is very poor, then probably we have to look into a holistical manner. So probably HbA1c of even 8 to 9 is also okay, because we are not looking into the chronic complications in such setting. Like the prognosis is very poor, the patient is not going to survive for many years. In such people, we should not go for strict diet control, and we should not go for very intensive control. Even the moderate, like the HbA1c of 8 to 9 is also okay. So in a very elderly individuals, more than 80 years, where there are no assistance available, children are staying away, there is nobody to look after other than the old couple. So in such situation, again, we can relax the HbA1c around 7 to 8%, or even just above 8% is also okay. So in pregnancy, we have to be very strict. So the HbA1c has to be below, ideally below 6. And otherwise also HbA1c is not that reliable during pregnancy. Even if you're doing it, it has to be below 6. So depending on the clinical condition, we have to change the HbA1c. So we have to make it tailor-made. So the HbA1c will change according to the clinical condition, sir.
Now I have one more question. Now, one doctor came to me, some 55-year-old doctor. So his HbA1c is 7. So I told him, he was asking me this question. He said, now I am not young and vibrant. I am now 50. So 50 is not a big age anyway. So he asked me, what is his HbA? What should be his HbA1c?
So is he having any other complications, sir? Diabetic related complications?
No, nothing.
So then if he's vibrant, dynamic, then energetic, will consider him very young, sir. So we'll keep him below around 6.5 only. So because we are also reaching near 50 now, so I can't call him old.
Oh, that is the thing. So I told him that the targets are there, but for doctors, the targets are different. The guidelines have not mentioned that, but for doctors, because they know what is hypoglycemia, everything they know. No. So because they know, their target should be less than 6.5 all the time. That's what I told him. But he was okay, asymptomatic. Yeah. So most of our patients, as you correctly said, the young people, because they have long years to live, their HbA1c has to be very strictly controlled. Because now they say for you to develop microvascular complications, because HbA1c is greatly associated with microvascular complications, as UKPDA showed, like let's say 1% reduction in HbA1c will reduce the microvascular complications by 37%, like that. So for you to develop microvascular complications, it takes time. Sometimes it takes up to about 10 years. So therefore, as you correctly said, very old person with comorbidities, limited life expectancy, we are not worried about, developing retinopathy after 10 years time. So what we are worried about is the acute complications of hyperglycemia, like, hypersmolar state causing problems, thrombosis and all that, or flourishing infections when the blood sugar is high, and worsening, myocardial damage in the case of heart attack. So that kind of situations in an elderly patient, we like to manage the hyperglycemia symptomatically, as you correctly said. So young person, yes, it has to be as strict as possible. But there are some other factors also coming in, not just the age and the comorbidity, sometimes the patient's affordability and the patient's education level. Because there are some people, whatever you say, they will just listen, and it's just a waste of your time, because they don't have the capacity to, take that in. So that kind of patients, if you load them with medications, they will develop complications of medications. And sometimes they will develop hypoglycemia and they will stop everything for years and years. So like that, the level of education and the affordability, we have to say that, and those things also matters. Yes, great. Now, let's ask the next question from Dr. Deepak Mall. What is the ideal body weight to maintain in a diabetic patient? What is, when it comes to, I know there are ethnic differences in body weight and the BMI. Now, let's say for us, for South Asians, what is the ideal body weight or the BMI that you should maintain?
Thank you, sir. I think this is also a very important question, and we're all worried about not only about our age, but we're also worried about our weight also. And whenever we talk, and whenever we see so many of our patients, we ask them to lose weight. Actually, losing weight is not an easy task. For diabetic patient, I'm always aware of, because they come in a fasting state and stay in a line for 4 to 6 hours, and again we ask them to go for a jogging and do not eat all these things, blah blah blah. And so I think we must be very, very flexible to our patients, that we must explain them actually what must be the ideal body weight for you. So it's not easy to lose the weight, but at least we have to advise them, go for a low carb diet, go for exercise and all these things. Ideal body weight in normal person, we can measure their height, and then height in centimeter minus 100. This is the ideal body weight. But if the patient is diabetes, so we can ask them to multiply by 0.9, and that will give us the ideal body weight of this patient. And we must ask them to maintain their BMI. We must ask them BMI that will give you the statistical measurement of a weight of a person is cleared according to the height. So we must ask them to maintain their BMI. Something like 18.5 to 25 might be the optimal weight. And if it is more than 25, then we call them overweight. And if it is more than 30, then we can be obesity, and that may be overweight. That might be the morbidity obese. So we ask them to calculate their height and weight, and we ask them to do. At the same time, not only weight, we must ask them to also to measure the waist hip ratio also. That is also very, very important, because most of our fats are in waist and hip, and we have, for male it's less than 0.9, and for women's it is less than 0.8. At the same time, to reduce the weight, we must ask them to go for a regular exercise. And this regular exercise will not only decrease the weight of the patient, at the same time, it will decrease the insulin requirement, OHA requirement, and all these things. Psychologically, well-being is also very, very important at the same time. And it will improve the glycemic control also, decrease the blood pressure also, decrease the risk of osteoporosis also, and improve the circulation and all these things. So I think if the patient is already thin, we are not supposed to ask him to lose weight. But if the patients are already obese with the BMI more than 25, we ask them to lose the weight. At least 10 to 15% of the ideal body weight can be decreased. So I think we must be very flexible as always also. So we must not ask them, we must not see our patient going in hypoglycemia, because I am always worried, because if the blood sugar is more than 250 also, patient can walk to your clinic and to your hospital. But if the patient gets in a hypoglycemic state, I think that will be another crime also. So this way we can ask the patient to maintain the weight.
Yes. Thank you, Dr. Deepak. And the next question goes to Dr. Sheila. Sheila, what is the blood pressure target of your diabetic patients?
So blood pressure target of my diabetic patients, before I actually get to it, I just wanted to put across something that's very important, that the BP is checked in the right way. We are increasingly having patients, coming to us with home blood pressure monitoring. I mean, we've actually, we face two situations. One, my patient who has a blood pressure which is actually high will tell me, madam, I saw your face or my BP बढ़ गया. I mean, if I'm allowed to break into colloquial language, then invariably it's like, I came into your clinic and I entered your hospital and my BP has gone up. Otherwise, I am absolutely fine. And mind you, this is without any monitoring evidence. Means they've not checked their BP. There is no this, but my BP is fine. It's only now that it's gone up. Yes, I mean, definitely I want to tell my patient that is sometimes possible if, for whatever reasons, in the sense that when you're coming to the hospital, it is known as white coat hypertension. So we all doctors accept that as a possibility. Having said that, but the bottom line remains that if you are having hypertension, please do not ignore it. A lot of our patients are very hesitant about starting hypertension medicine. We need to understand it goes hand in hand. Diabetes and hypertension are strong companions. They are almost like comrades in battle. And when they attack you together, the results are very, very devastating. So when you're talking about measuring BP, sir, even at home, like a lot of my patients now have a home blood pressure monitor. Nowadays, Diwali gifting has been BP monitors and glucometers. We've been telling our patients, please don't give sweets. Please give the person you love a glucometer this time, or give them a good BP machine. I think it's very important that they sit down in a sitting position, keep their arm at the level of the heart, and check the BP in a comfortable position with their feet flat on the ground. I think if patients start understanding that, and don't get very worked up when the numbers are not what Dr. Google is saying. I mean, I'm sure sir will talk about Dr. Google also. And if that's when you're targeting, if your patient is at a high risk of cardiovascular disorders, the 10-year risk that your clinician will calculate and tell you, okay, you're at a high risk. Your clinician is then going to target your BP to be less than 130/80 as long as it is safely achievable. If your risk is not that high, then your doctor is going to be happy with less than 140/90 with whatever medications they want to be using in you. So that would be a decision which your doctor would make with you as to which, if you are going to go much lower, it will be a very, very individual decision. Otherwise, if you're a newly diagnosed diabetic with hypertension, most of us are happy with a BP of less than 140/90. But please check that BP.
Yeah, exactly. Now the thing is, now some of the patients bring their home blood sugar meter to us and then ask us to check the blood pressure meter. We check it and then they will check with their meter. And if it is slightly different, then they are very much worried. Now, regarding this white coat hypertension, there are patients who who every day says that my blood pressure goes up when I come to hospital. Now, what I say is, even when you come to hospital, the blood pressure can't be this high. Because if it is, let's say, 180 by 100, so we can't ignore it. So if we take it as white coat hypertension, then we should arrange them to have home blood pressure monitoring. So then only we can monitor that. We can say that, but still, even the white coat hypertension people will have problems like, the retinopathy, the hypertensive retinopathy and the complications. So when it comes to diabetics, as you correctly said, the patients are very reluctant to get the label that they have high blood pressure. So they want to avoid the tablet. So sometimes same for statins also. So then I say, if you take treatment, then the risk of heart attack will be reduced by 20%. But it's your options. If you don't want, then fine. Then they will, all agree to take tablet. So somehow we have to convince. No, that is how the Western medicine works. No, you don't wait till you get the heart attack, but you have to prevent it. Yes, very well said, Dr. Sheila. Next, let me ask Dr. Ganesh again. What is the cholesterol targets of your patients, diabetic patients?
Yes, sir. So there is one more comrade in the battle now, the cholesterol actually, along with the diabetes and blood pressure. That also has to be under control, so as to prevent the long-term complications like heart attack or paralysis. To prevent these complications, we have to keep the cholesterol also under check. There are so many cholesterol parameters. I'll just tell the numbers. Total cholesterol, if there is something called as total cholesterol, which has to be below 200 in many of the times. If the first time, if the cholesterol is 200, then you can 200 plus. We can ask the patients to do diet and exercise, and it can come down by around 10 to 20%. It can't come below 10 or 20% because all cholesterol doesn't come from the diet. At least 80% of the cholesterol, whatever is there, which is showing in the blood report, it comes from the liver. So that is the reason the people can reduce their cholesterol only by 10 to 20%, not more than that. So that we have to emphasize. Or we can give a trial of months or maximum 3 months of diet and lifestyle modification, so that whether it can comes under control, we can see that. If it is not coming under control, probably we have to give some medication. Another cholesterol, bad cholesterol, what we call it as bad cholesterol is LDL cholesterol. That has to be below 100. So 100 mg per deciliter. So in patients who had heart attack or stroke, in such situations, probably it is better to keep it below 70, or else otherwise in all diabetics, it has to be kept below 100. So other parameters, triglyceride, it has to be kept below 150. And one more is good cholesterol. So good cholesterol is actually by doing exercise, by regular physical activity, we can increase the good cholesterol, HDL. So it has to be above 40 in males and above 50 in women. So we can keep the cholesterol under this range, sir, like this.
Yeah. Yes, true. Yes. We must promote most of our diabetic patients to take statins. When it comes to statins, one of the habits that our patients, at least in Sri Lanka, are having is they will take atorvastatin, they reduce it to 5 milligram, and then they will start taking 5 milligram every other day. And then after some time, they will start to take 5 milligram once a week. Like that, they themselves tail off the statins.
Yes, sir.
So what do you say to such patients?
In India, it's even worse, sir. They take for only one strip, that is 10 tablets. And after that, and they ask the pharmacist which is for diabetes and which is for blood pressure and which is for cholesterol. So for diabetes, they take for 2 months, the blood pressure for 2 months, and cholesterol only for 10 days. After that, next time they will come with again the same lipid profile.
Yeah, that's the thing. And the thing is, now with statins, the cholesterol will come down. But when you stop statins, it will quickly go up. Now, I say patients that atorvastatin, you can go up to 80 milligram, but I am going to give you only 1/8 of the dose, that is 10 milligram. Otherwise, they are scared. They are scared that they will get something by just taking the tablet. So 1/8, but if you take less than that, the cholesterol can be low, but you are not protected against the heart attacks, because it is not only the lowering of the blood cholesterol level, but the other effect of statins like plaque stabilization and all those things matter a lot when it comes to reduction of actual heart attacks. So actually, it is a very hard situation in Sri Lanka to convince people to take statins, but something that is very, very rewarding if you put them on statins and if they are compliant with that. Yes. Now let me ask Dr. Deepak, what do you mean by target in range or TIR concept?
Thank you, sir. Again, we are here in a target. Life is our life is very squeezing in targets, and still we are asking our patient, come with this report, and I don't know how long we can do. We as a physician will spend our life with our patients with squeezing them. So it's a very new thing in time and range. It's a very new thing. After I got through this and I went through some of the papers and I found it. Actually, in my country where I'm practicing as a endocrinologist in National Academy of Medical Science in Nepal, we don't do so much of continuous glucose monitoring machine. We don't put all these things in our patients because, as you know, in some of our patients are already in so much of drugs, and we don't want to keep them in a financial burden of keeping all these new gadgets in their arms and abdomen. So at the same time, time spent in target range is very, very important. How much time are you spending in a range that you want to keep your blood sugar from 70 to 180? It's very important. Actually, Dr. Ganesh and Dr. Shela has already mentioned that the role of HbA1c is very, very important. But there are some kind of limitations in HbA1c that during the pregnancy time, during anemia time, during iron deficiency anemia, and then during such kind of hemoglobinopathies, that there might be some kind of fluctuations of HbA1c. So now the concept is new that how can we live with HbA1c and complications at the same time, mean blood glucose level and complications. The HbA1c is measured which will give us a virtual idea of 3 months of blood sugar control and the way of our patient's body is going for complications. At the same time, it will not give us the inability to present the acute glycemic reports. So this is a new concept came in the time of range, and this actually is from so many experts from I think from Brazil. They were trying to do all these kind of things. It will define the concept of time spent in the target range between 70 to 180. Actually, it is very easy to be monitored. How the blood sugar levels are going in hours, in every moment, like if the patient going to hypo or he's in a hyperglycemic state. So actually 14 days of CGMS report will be displayed in a graph, and you will be able to see how the patient is cooperating with his hypos and how the patient is cooperating with his hypers and all these things. So it's a very new concept, and I don't know if it is been practiced in India, in Sri Lanka or our neighbor countries. But I haven't seen any of our patients practicing here in our place. So it's a very new concept, and I think we need to be very focused with type 1 and type 2 diabetes patient with 70 to 140. If the lady is pregnant, we can go for 63 to 140 of the target. So it's a very new concept we are getting, Dr. Chaminda, and I think we in Southeast Asia also will be practicing all these things.
Yeah, actually, yeah. As you correctly said, we are not really looking at the glycemic exposure of the patients. We have HbA1c as a surrogate marker, but there can be a lot of fluctuation in between because somebody can have very high blood sugar and very low blood sugar, and the HbA1c can be maintained at the desired level, but still he is able to get all the complications like that. It's a new concept, and I think in time to come, when we get CGM and all that, we will have all the facilities to do this. Let me ask Dr. Sheila. So, what is your view on social media messages on improving the diabetes care of patients?
Sir, I love and at the same time hate social media, if I'm allowed to say that. Love it because it's the best way to connect. I mean, there's nothing to beat social media, beat whichever means you want. Finally, we reach out to each other by communication. So when we are communicating, but the biggest issue is that the communication should be right. From it starts from the right source. Because, for example, the very reason, sir, we've all, joined together today is to communicate to our patients out there, to communicate to not only patients, to their families, to the public in general, about why are we talking about diabetes. So this platform is the right communication platform. But if you, for example, if any of my patients Googles out there, so you have n number of sites with n number of people giving you n kinds of opinions. So I think it's very, very important that we use social media very, very judiciously. Our patients out there, our friends out there, so many people, I would say non-medical people out there know which platform to reach out when they need genuine medical information. And that's the day, because sir, now what's happening is in my clinic, I have patients coming to me with a diagnosis. Madam, I have this. Then it's like, and who told you this? And oh, madam, I Googled, and it's supposed to be, oh my God, why are you not appreciating the fact that I've Googled and come to you? So the biggest competition at this point of time is Dr. Google from the wrong sources. So if we can put it across, and I think the ESI website, the ESI Facebook page, the SAFES Facebook page, I'm sure everybody out there in your respective countries must be having their respective websites. I would like to tell everybody out there, please go to genuine medical websites. Please go to the ESI or whichever professional website you are following, or the SAFES. I'm sorry, sir. Chaminda, sir, you can tell your local website, and Dr. Deepak can tell his local website. Go there for good information, genuine information, and listen to your doctor. Your doctor wants you to be fine. We are interested in your health. We want you to be fine. Don't use social media as the platform to go to with your problems. If you need a little more understanding, because I understand we all are busy and we are social animals, we will communicate with each other. So when you are communicating with each other, communicate in a way which gives you the best information. It's like a sieve, sir. You remove the bad information and only retain the good. So as I said, I think social media is very, very important. It's the best way to reach out. We all at the click of a button, reach out to each other. Mohan is our social media king. I can't survive without Mohan at this point of time. So, but at the same time, we need to be sure as to where do we reach out so that you get the right information.
Yeah, you very, very, very well said, Dr. Sheila. Actually, you have to go for authoritative websites, contents, professional websites and all that. So there are blogs operated by individual people. Some people want to increase their views, number of views, contributors, like that. But you have to go by the websites of the professional associations like SAFES, ESI, and we have our website, Sri Lanka College of Endocrinologists. I hope all the other countries have that website. If not, we go by American Diabetes Association and NHS websites, and so like that. So not the Google doctor, as you correctly said. Now, before we conclude, can I ask our each panelist just to give us a summary of or some take-home messages from what you have been speaking so far? Let me ask Dr. Ganesh, just tell us a few things that an ordinary person with diabetes should be, concerned about when it comes to the control of diabetes.
Yes, sir. A diabetic person has to do a proper lifestyle modification, regular diet and exercise, take his medications as advised, so that he can keep all the numbers in check: fasting, PP, HbA1c, lipid profile, and blood pressure, as well as other parameters. So he has to do proper lifestyle modification, diet, exercise, plus medications as advised. That's all, sir.
Very correct. Yeah. I always say that diet, exercise, medication, and monitoring. So that is what is needed. Dr. Deepak?
Thank you, sir. I think take-home messages must be, we must be happy, our patients must be happy. Whenever they go to bed, they must sleep well, they must spend time with their family, they must talk with their kids, they must go out with their parents, have some dinner with them, talk to them. I think this kind of activities, we all must ask our patient to do. I think this will also decrease the blood sugar level. Let's not keep our patients in a hypoglycemic state. Let them enjoy their life, but at the same time, I think there are so many ways how we can enjoy our life with diabetes. So we must convey this to all of them. Thank you.
Yeah. Dr. Sheila, please tell us a few words.
I agree with Ganesh and Deepak, and I'll just add, educate yourself and empower yourself. If you educate yourself, you teach knowledge is the best way forward. There's no going back then. And definitely what Ganesh and Deepak had. It's a combination of everything put together.
Yeah. Thank you, everybody. As you correctly said, patients, they have their own life. They have their lifestyle, they have their connection, social media, whatever. And sometimes diabetes is the prime concern of us, but the patient does not take it that serious. But still, we should not upset the patient's perceptions about the life just because he has diabetes, because it is easily treatable and controllable disease. So we should always give the positive side of the diabetes to the patients at each point, and we have to intervene with them in a friendly manner. We should not be threatening. We should always give them information, and we should judge their capacity, and we should put our words according to the capacity of the patient. So it has been a pleasure talking to these three experts from our SAFES countries, and I think it would have been very useful to our listeners as well. And I must again thank the Endocrine Society of India and SAFES for organizing this event. And thank you very much. Ayubowan, namaste.
Namaste.
Thank you, sir. Thank you. Ayubowan, sir.
Thank you. Thank you.
Thank you so
Thank
much.
you.
So from that discussion, I think we have learned many points. To just sum it up, it will be ABCs. So you just check your HbA1c and check, keep it in the target. Then B is for blood pressure. C is for the cholesterol levels. Of course, D means you should prevent diabetes or obesity. So that means weight also should be in control. So holistic management of diabetes is our aim. So that is why we are leading this war against diabetes with this activity. L stands for learn, E for education, A for awareness, advocacy, as well as finally we have to collaborate as well. So thank you, panelists. Thank you, moderators, sir, for the excellent points made. So let us move on to the next session. So the next panel discussion, the topic is do it yourself in diabetes. It is a very new concept which has happened from the last several years. American Diabetes Association has also recognized that individual is the center of attention and personalized medicine is also important. So to lead this panel discussion, the moderator is Dr. Professor Sarita Bajaj, madam. To introduce her in a it will be very long, but just a few lines about madam. Madam is associated as a professor and HOD previously at the MLN Medical College in Prayagraj, previously called Allahabad in Uttar Pradesh, India. She has been past president of the SAFES, founder president as well, then president of ESI 2010 to 11. President of RSSDI. She has got an oration established in her own name in RSSDI in UP 2018 onwards. Several publications, more than 200 in national international papers, as well as one of the great books I have read is Endocrine Society of India's Manual of Clinical Medicine and Endocrinology. Welcome, madam. Madam is having keen interest in endocrine education, thyroidology, and obesity. Lifetime award in Diabetes India as well as Uttar Pradesh Diabetic Association. Namaskar, madam.
Thank you. Thank you.
So the next is Dr. Shivartasya Padmanabhan. She is from Sri Lanka. She is consultant endocrinologist in National Hospital of Sri Lanka, overseas trained at Christie Hospital, Manchester, UK, consultant endocrinologist in Sri Lanka, as well as she has a lot of guidelines she has written, and she's in a member of specialist board in endocrinology, metabolism. She has been trained in a good centers and special interest in pituitary, adrenals, and neuroendocrine tumors. Welcome, madam.
Namaste.
Amen. So also we have with us Dr. Uruj Lal Rahman. Madam is from our neighboring country, Pakistan. She is affiliated to the Jinnah Postgraduate Medical Center and Jinnah Sindh Medical University, Karachi. She has published so many articles recently, pattern of pituitary lesions in endocrine centers, C-reactive protein marker in type 2 diabetic nephropathy, so many articles regarding gender misalignment, also on normotensive pheochromocytoma. She's having research interest in diabetes, pituitary, and disorders of sexual development. Welcome, madam, to our panel.
Thank you.
So these are the three panelists, and we have at least 45 to 50 minutes time. We can go on for a long time, but we have to have an expert discussion. Over to you, madam. Do it yourself.
Dr. Manoj Chadha.
Yeah, doctor. Yeah, sorry. Yeah, Dr. Manoj Chadha, sir, to just complete.
So excited with his neighbors that he forgot his own.
Yes. Sorry, ma'am. Dr. Manoj Chadha, sir, is also with us. Sir is the president, he's past president of ESI, and he's associated with PD Hinduja Hospital and Hope and Care Center, Navi Mumbai. He DNB endocrinology teacher 2008, ex-faculty at KEM as well as BLYL Nair DNM Medical College. He's trained in artificial pancreas biostat at University of Ulm, Germany. I got the pronunciation right, I suppose. So she is also a member of Asia Pacific Regional Committee of IOF, or International Osteoporosis Federation. Apologies, sir. I just not, sorry, sir. So thank you, madam. So please take over, ma'am.
Thank you. Thank you, Mohan. And I will like to ditto what Shaila said, that you have been a very, very important part of this meeting. So thank you, and a very, very warm welcome to everyone amongst, of course, our panelists and the audience, because this program cannot be successful without an audience, which we are targeting, the public. This is a public platform educative program. It's a joint initiative of the Endocrine Society of India and the South Asian Federation of Endocrine Societies. Mohan has already said it's Lead the War Against Diabetes. I think we are all aware of the fact that amongst the 4 pillars of diabetes management, diet, physical activity, medication, the most neglected is education. So over the week-long program that we are doing for World Diabetes Day, remember, it's not a day. The day, so-called day, which was started in IDF way back in 91, is 14th November. But actually, it is a week. So I would really like to congratulate the Endocrine Society of India, as well as SAFES, for continually doing a public activity throughout the week. And the theme this year is access to diabetes care. You've just heard about the making sense of the numbers, the scores and goals. So our panel will be talking about do it yourself in diabetes. So I would like to, of course, congratulate Dr. Chaminda. That was excellently moderated session. And Dr. Ganesh, Dr. Deepak, and Dr. Shaila, their contribution was fabulous. Just to keep you updated as to what you are to expect in the coming 2 days, that you will be talking about, we'll be talking about the drugs, the medicines for diabetes, your partners in care, and the complications on the last day, that is stitch in time saves 9, so that you are prepared as to what you are expecting in the coming 2 days. Now, such an initiative is not possible without team effort. And the team comprises the whole of the organizing committee. From the patrons, we have Dr. Sanjay Kalra, Dr. Rakesh Sahai, Dr. Sujoy Ghosh, Dr. KVS Harikumar. The international patrons are Dr. Noel Somasundaram, Dr. Abbas Raza, Dr. Farooq Pathan, Dr. A.H. Amir, Dr. Faria Afsana, Dr. Prashad Katulanda, Dr. Ali Latif, Dr. Robin Maski, Dr. Ibrar Ahmed, Dr. Ahmed Zia, and Dr. Muhammad Wali Nasiri. The organizing chairperson, Dr. Deena Shrestha, who is the current president of the endocrine, I beg your pardon, of South Asian Federation of Endocrine Societies, and the president of the Endocrine Societies, Dr. Ganpati Bantwal. Scientific chairperson, you've already heard Dr. Shaila in action, and Dr. Saptarshi has been really working very hard to get this program in place. Dr. Nitin Kapoor and Arundhati are the organizing secretaries. The scientific secretary, Dr. Nalin, Dr. Nalini Kopale, Dr. Mohan we have with us, and Dr. Anshita. And the scientific co-secretaries are Dr. Lakshmi Nagendra and Dr. Sunetra Mundu. So now starting off with the panel discussion on do-it-yourself. So the first question, which I would like to address, is to Dr. Manoj. So Manoj, could you start off and just let the audience know as to what is this do-it-yourself concept?
Good evening, Sarita, and thank you for having me on the panel. So this do-it-your concept, I mean, if you just look at what's happening at home, there are so many things that you just pick up from the market and come and fix it up and start using it. So that is probably for other things. When it comes to diabetes, you know, unlike the acute illness that happens in our patients, where you go to the doctor and the doctor gives you a prescription and you follow it to the T without asking questions. But when it comes to chronic, these non-communicable disorders, and today we are talking about diabetes, it's a 50-50 partnership. The doctor gives you a prescription, you keep it in your file and don't open it till the next visit. Not a good idea. You have to talk to your doctor. The doctor is talking to you, and you are equally responsible. So we've had this discussion about diet, we've had exercise, regular checkup, follow-ups, which is again what we are going to be discussing more on this panel. But the patient is equally responsible. He has to be empowered. So that's where this whole focus on educating the patient. I think even public awareness, because it's not only patient awareness, relative awareness, public awareness. Because so often today, when you ask someone, how did you come to me? Oh, I had a regular checkup, or I found some ants around the, urinal when I passed urine. So something which they are hearing from the public. And that's what is good. So when we say do it yourself concept, I think in concise thing is they have to understand, they have to be with us, the medications, the numbers, the side effects, the follow-ups, all that is a part of this whole initiative.
Thank you, Manoj. So what you are trying to convey is that at the end of the day, the patient is responsible for his or her diabetes care. So they need to be at least aware of, like in the earlier panel discussion, they were told about when to test, what needs to be tested, how frequently to be tested, what are the targets. So they should be aware of that. But the medication jugglery, I think that they should leave to the doctor.
Yeah, probably towards the end when it comes to medication, although today we are not discussing medication, but we don't want them fidgeting with the tablets. Aadha goli extra le liya, aadha goli kam kar diya. But insulin, we definitely want them to be understand how to go about it. Probably we'll discuss that down the line.
Absolutely. The insulin part is very important. And unfortunately, in India, we lack the diabetes educators. I won't say nurse educators, should be just educator. So unless we have that link in between, those, the complexities of at least, especially insulin, are a bit tough. So we'll now move on to Dr. Siva Tharsya. I think, is it okay if I call you Dr. Siva?
Yes, ma'am. I think that will be easy.
That will be nice. Yeah. Okay. So, right. Again, a very, very warm welcome to you. So, like we were just talking about the patient as an individual, but the patient is not an individual. We have the family who is going to be also responsible for the management, isn't it? So what would you say is the role of the family and peer support in the management of diabetes?
Thank you, ma'am. As well as I thank all the organizers for actually inviting me. It's a great honor, as well as, it's a great platform to meet you all. So yes, individually, although in our South Asian region, we live in a not a single unit as family. We usually live in a joint family setup, which actually I think is a good family unit which helps in case of diabetes management. Of course, everyone would agree with me. Patients who have the greatest family support do well with their diabetes. It is not only the family support, because some of these patients that we have, especially who have a lot of comorbidities and elderly people, they lack in their knowledge, so they don't know what to how they have to follow certain things. And then in that case, probably the family should take the role and probably support the patients so that they can follow the advice of the doctors. Because it's not only the glycemic control, it's the control of the comorbidities, how you manage your medications. And there are a lot of factors that interfere with the success of the diabetes management. For instance, the financial thing that plays a major role, as well as, the knowledge, And when they have a lot of comorbidities, they had to probably visit more than one subspecialist. So it's the family support that is very important for them to stick to their targets. And especially, you would have seen in your day-to-day practice, some elderly people who do not follow what we say because of their probably lack of knowledge or probably risk of side effects, especially hypoglycemia in patients who are using insulin. So probably, empowering the knowledge, not only on patients, but with their family members, really help to improve the glycemic control as well as the overall well-being of the patient.
So I'm a very passionate proponent of women's health. So apart from women, I don't know what is the setup like in your country. Like children are dependent on the family or mother, father, right? What women are also dependent on the family for even going to the doctor, for being provided the medication and all. So don't you think, and the elderly as well? Like you say you have a joint family set up quite often in Sri Lanka. So don't you think the children, women and elderly, because they need so much more support, like even for a woman to go to a doctor can be difficult sometimes until somebody is escorting her. Same applies for the elderly as well, and same for children. So what sort of, what advice do you have over there?
Certainly, ma'am. In the family unit, usually the ladies or females are probably the neglected sub-cohort, I would say. Like when they try to prioritize the thing to probably the husband or probably the children more. And they are the ones who try to seek medical assistance at the last, especially like when it comes to financial constraints, by medicine and all. They would prioritize that to their husband. Probably they would, stick to their husband's doctor schedule appointments, probably their children one, but probably they neglect. So we see that. And that is a common thing. And probably that is one reason they probably don't come to the clinics or probably don't follow. So in my practice, I think probably that is what you see in your practice as well. We try to get hold of the family member and try to convey things, especially women who really need the care. Usually it works. Actually, if you speak to the family, they realize most of the times when the female comes alone to the clinic visit, they don't convey the things that probably, they might have developed a microvascular complication, probably a retinopathy or maculopathy which needs urgent attention. But they tend to hide things from the family, trying to prioritize the things. So in that case, we always try to contact the family. So that really works. And I'm sure that is the same scenario in other Southeast countries as well.
Similarly for diet as well. I think whoever is responsible for the kitchen must be there in the counseling session, in the education, because otherwise, who's going to take care of the diet part? And if there's already a diabetic at home, then I think that also helps as far as the family is concerned. A very warm welcome to you, Dr. Roos. Could you please tell us what you think about the lifestyle changes that are required in diabetes?
Thank you, ma'am, for having me. First of all, I want to be thankful to the SAFES and to the Endocrine Society of India. A very good initiative, I must say, very important for awareness. These programs are very much needed. The way the numbers are climbing over the time. Scary numbers coming up, hopefully in a few days. So lifestyle modification, cornerstone of the treatment. First thing first is lifestyle modification. We have to talk to the patients because it's actually the lifestyle, the numbers which are rising are basically because of the lifestyle. It's time for prevention, and prevention is all with the lifestyle. And what is included in the lifestyle is diet and exercise. Not one thing diet, only diet, doing dieting, it will help, or just doing exercise will help. Both of them together will help them, help prevent the diabetes and help control the diabetes and help the prevent the progression of the diabetes. So diet, there has been a session already, a very detailed session on diet, so I will not go. It's just that we need to change the ways we are now having our foods. This is the era of the tabs and era of touch, and somehow, I don't know about other, but our country and people have become foodies. Now they just want food, whether it is a happy occasion and unfortunately a sad occasion. They just want to eat. And there is a mindset that, okay, I'm having a plate of biryani. Biryani is very favorite here. So if I'm having a plate of biryani, next day I'll just go and have a 1 hour exercise and it will burn. No, the calories won't burn, because we are the people whose ancestors have been going through difficult times. And so we have this kind of genes known as thrifty genes. So we have this ability of storing the fat in different places and the wrong places. And that leads to complications. So you cannot burn everything which you're eating. So you have to look at what you're eating, and it has to be balanced. Everything, the carbs, the fats, the proteins, everything has to be there. So that's about the diet. Coming to the exercise part. So exercise, again, maybe it's the type of the food we are eating, which is leading to this, that we have become we don't want to exercise. We are becoming lazy. We don't want to walk. We don't want to take stairs. We love to take, go by escalators or by elevators, but we don't like to take the stairs. It's a single flight of stairs can be helpful. I'm sorry for the, you can hear baby. So it is recommended for everyone, either diabetic or a non-diabetic. So 30 minutes of exercise per day for 5 days, which is a moderate intensity exercise, which is a walk. And mind me, this walk, you don't need to go out in the park to walk. You don't need to go to the to a street or outside. You can do this walk inside the house, in your room, just at one place. You take the steps and you can walk. So you do this, or you can do a vigorous exercise by going like running 25 minutes 3 times a week. Along with it, you have to do a strengthening exercise twice a week for the muscle strengthening. And that exercise doesn't need a gym. You can just use the water bottles. Mind that these water bottles are filled with water, not the empty bottles. So that's you need to do. This is for the healthy and diabetic patients. They all can do this. For children, it is recommended 3 to 5 years old children, it is recommended 3 hours play every day. For young 6 to 17 years old, it is 1 hour play every day. In case of diabetes, only the important thing is that these diabetic patients, before going for any kind of vigorous activity, they should go and check with the doctor and look for the complications. If there's microvascular or macrovascular complications or cardiovascular complications, especially the eye has to be checked, because if there is proliferative retinopathy, that is, there is formation of vessels at the back of the eye, then there is chances that highly vigorous activity might lead to bleed there. So that has to be taken. So anyone who is more than 35 years of age has had type 1 diabetes for more than 15 years or type 2 diabetes for more than 20 years, before embarking on any kind of vigorous activity and exercise, should go to a doctor and get himself or herself evaluated. So that's
very nice. Very nice. Very nice. Thank you, Dr. Roos.
Thank you.
So I think basically what we are trying to convey is that the cornerstone of management is lifestyle for every diabetic throughout life. It's not just a 1 day, 1 month, 1 year, 10 years, it's forever. It's almost 365 days in a year. And the persistence, the consistency has to be maintained. Like you said, you cannot freak out and then balance it the next day. And the calories have to be balanced. throughout in that one particular day. So you have an account, and if you overstep it, then the blood glucose is definitely going to go haywire. So this is very, very important. Thank you, Dr. Roos. We are going to step up a little and talk of some things that maybe we're not all able to practice, but they are there. So the awareness, we're trying to create awareness about what's new. If you're aware of it, perhaps you can actually start doing it. So this is really from the patient's awareness perspective. So Manoj, we were talking about blood glucose monitoring in the previous panel. Can we step up? What about using a digital logbook or SMBG chart? So what are the different glucose monitoring patterns that can, help people if they are savvy? And which techno savvy? Yes, the younger generation is getting very techno savvy.
I think, patients are used to this, getting a blood sugar done once in 2 months, once in 3 months, and coming to the doctor. So I explained to them, this is like taking a photograph. If they do monitoring at home in a particular pattern, which we generally talk to them, say twice a day or 4 times a day or 4 times a week, depending upon the medication that is going on, their clinical status, complications, pregnancy, we keep changing the advice. But the important thing is more frequent monitoring gives you a better picture. And now the latest that we have, the continuous glucose monitoring, where you have a sensor which monitors your sugars for 14 days, every 15 minutes. So that's like seeing a video film. You see, so you get one picture, you get a set of pictures, or you get a video film. Obviously, your understanding is better. You can have the target points, the irritants, the good points, how exercise makes a difference, how eating a cake piece makes a difference. So that gives you an idea. Now, what would be best or convenient for everyone is to make an Excel sheet, make columns from date, and then the different before breakfast, after breakfast, before lunch, after lunch, before dinner, and after dinner. So I tell my patients, do it yourself and keep a column for remark. Because after 3 weeks or 6 weeks, if there has been a reading of 350 or 50, they may not remember what happened. So make a remark there. And they can do it at random. They can do it in pairs, whatever is possible. And I repeat, more the tests, more the information, better the control. Just simple monitoring can improve your control. That has been shown. So that is something which we need to stress on. Yes, today we have apps now. You just enter, you sign up with one of the apps, enter your information, the glucose values, your medication that you are taking. There are some apps which even ask you for the meal that you have taken. And it really gives you a feedback, okay, how things are going on and what you can modify. So I'm really happy with, ensuring that my patients, what we started saying by empowerment, that's one of the ways of empowering them. So they can look for themselves and realize for themselves.
Thank you. So in the, like in the digital era, like your patient is sitting at home, sending the data across to you. So I think that is a big help as well. So the patient doesn't actually need to come down to the clinic. And when you've been doing consultation, telemedicine, I think that has been very helpful as well. Plus, I think there are new phones in which you can just like a pen drive, plug in your data and everything is visible. So I think that is a digital logbook. That would also be very valuable. I mean, that's very valuable rather than avoiding the pen and paper. But I think that what you have said is to maintain an Excel sheet is, I think, the simplest, easily doable, and very user-friendly as well. So if they maintain that log and they come back to you. So without that data, we cannot process.
Yeah,
and it's not just one sugar. So, like you said, if they've recorded it 2 weeks back, like for Diwali, I'm sure there were so many of them having sweets. And then obviously if the sugar shot up, so we have an answer to that. So we don't, drastically change anything. We know this was the reason. We will correct the reason. Like Uru said, if they haven't done their exercise and the sugar goes up, but then you do your exercise and try to see what happens. So that is the importance of the data that comes to us. Okay, back to you, Dr. Shiva. So screening for target organ damage. Some of it has been discussed, but just, to be absolutely crystal clear, these are the tests that you really need to do for target organ damage. So what are the organs that we worry about and the tests?
So in the end organ screening, we mainly screen for micro and macrovascular complications. So in a type 2 diabetic patients, you have to screen from the onset of diabetes, because there must be a period of pre-diabetes where, without the patient's knowledge, patient must be having increased glycemic risk. And the studies have found the macrovascular complications starts even in the pre-diabetes state. But the microvascular complication starts with the onset of diabetes. So in type 2 diabetes, with the onset of diabetes, you have to screen for complications on an annual basis. And the frequency will change depending on the findings. In a type 1 diabetes, of course, you start the screening at the end of 5 years. So if you take the micro and the macrovascular complications, in the microvascular complications, you screen for your retinopathy problem, you screen for diabetic kidney disease, and you screen for diabetic neuropathy, and especially at-risk foot. And in the macrovascular complication, you screen for ischemic heart disease, stroke, and peripheral vascular disease. So to screen for retinopathy, you have to see your ophthalmologist or optometrist who can do a detailed eye examination at least once a year. And depending on the findings, he will direct you how often you have to probably see them, whether it is again an annual or probably like every 6 months, or whether you need any immediate intervention and you have to see your ophthalmologist immediately. When you come to the diabetic kidney disease, there is 2 ways that you assess the at-risk kidneys. You do your urine microalbumin or albumin creatinine ratio, where it gives an indication of the early diabetic kidney disease, where you have the tendency to leak the proteins in your urine. And then serum creatine, that is probably is reflected slightly later, but more than creatine, EGFR is a good indicator of your involvement of the kidneys. And then the diabetic neuropathy, where you have to screen for at-risk foot. So at least you have to do your monofilament test to, like identify your early stages of peripheral neuropathy. And probably that could be done with a diabetic educator nurse, or in a setup where you have all the full-fledged diabetic clinic. They can do with a biphysiometer. And coming to the macrovascular complications, how you can monitor, probably you can monitor your blood pressure, which has been extensively told by Dr. Sheila in the first panel of the discussion, where you have to make sure that you monitor your blood pressure correctly. And if you can visit your doctor with the blood pressure monitoring, that will help your doctor to adjust your medication, as well as probably maintaining the normal blood pressure will help you to alleviate most of these micro and macrovascular complications. So if your blood pressure is not well controlled, it is an indicator that probably whether you have to be screened for your heart disease as well as your kidneys, because blood pressure plays a major role in the development of micro and macrovascular complications. As well as, you can probably monitor your lipids, and the important observation that was elicited in the first panel of discussion is people tend to stop their anti-lipid medications. So, it's again education reinforcement during their clinic visits. They have to monitor their lipid profile, and they have to continue their lipid medication to prevent getting mainly the macro as well as the microvascular complications. So this the common scenario that we see is they do a lipid profile on their own, and probably when the lipid profile is normal or probably within the targets, they stop their anti-lipid medication. So we have to reinforce to the patients, and what I would like to tell at this point to all those who have joined is, probably your lipid profile is good, or probably you are seeing excellent results just because you are continuing your lipid medication. So don't stop it. And lipid, especially statins, they not only reduce your probably the false thing that patients think is it only reduces your lipid levels. No, it has other benefits, probably stabilizing the plaque formation and things. So continue your lipid medication, and without the knowledge of your the treating doctor, you shouldn't stop any of the medication. So screening for diabetes, as I told you, screening for micro and microvascular complications, usually they are done on an annual basis, but probably your healthcare provider will ask you to see them more frequently than the annual thing if they detect any early signs of this development.
Thank you. I think that was very, very well conveyed. Just one complication, because we were talking about the family last time. What about they should be aware of this, the fact that nephropathy is transmitted. In other words, if there is a family member with diabetes who has diabetic nephropathy, then their chances of developing nephropathy are much greater. So they really, really need to take care of their kidneys. Of course, like you said, the regular checkup, and we must focus on not only the creatinine, but the eGFR, the estimated glomerular filtration rate. That is very important for making a lot of decisions. So I think that has been very, very well conveyed. And regularity of these tests, not to stop the medication, maybe step down if at all, depending on what the healthcare provider says. So that's really very, very well conveyed. Dr. Uruz, in the reproductive age group, what would you advise regarding pre-pregnancy planning? You are mute.
Yes, sorry. Okay, pre-pregnancy planning, I'm so sorry. Very important, very, very important, especially in our setups, because over here, after marriage, pregnancy is expected. And the question asked by the family is about pregnancy. So it is a very, very important thing that we should counsel our new couples about pregnancy and about pre-planning of the pregnancy. So anyone
okay, don't worry, we will manage.
Okay. Anyone who's diabetic,
I want you to be comfortable.
I know, I'm so sorry. She's just very cranky today. Okay, so counseling is very important, especially because you are giving them treatment. Diabetic patients, you're giving them treatment, and these treatments can lead to a lot of complications during pregnancy. Then diabetes itself can cause a lot of complications, not only for the mother, but for the baby as well, the malformations, and even the IUDs and the stillbirths and the miscarriages. Then in mother, there can be chances of preeclampsia, hemorrhages, and hypoglycemias. So they have to be counseled, and they have to be told that whenever they are planning, when they want the pregnancy, they have to do few things. first of all, they have to get their medications changed. So like ACE inhibitors and statins, if they are on that has to be stopped, because first 2 months, if they are pregnant, we don't know, and these can cause complications in the baby. Then HbA1c is very important. So 6.5 or lower HbA1c is recommended in these women. If the HbA1c is more than 10, they are not allowed to get pregnant. They should not get pregnant. Then weight. They have to bring down their weight. The BMI, the cutoffs of BMI for Caucasian and others is 18 to 25. For us, because we have smaller frames, and so our cutoff is 23. So they have to bring down their weight and BMI within the range. They also have to blood pressure. They have to work on their blood pressure. The blood pressure should be an ideal blood pressure between 120/80. The ideal blood pressure they should be on. And then again, if they are not planning for pregnancy, then they should know that, because most of them, the first line treatment is metformin, and metformin increases the sensitivity. It also causes ovulation. So some of them, so contraception, the contraception needs to be explained to them, that they need to take contraception. They might get pregnant even if they don't want, and they are on the treatment which can help them in getting pregnant. So these are a few things which have to be counseling is the main thing, and these all have to be explained to them.
So important thing is that when we talk of hyperglycemia in pregnancy, so it's how do we decide whether this woman was a known diabetic, if she's not a known diabetic? Oh. If she's a known diabetic, absolutely. Even before marriage, they need to be counseled. That you need to be very, very well controlled. You've already mentioned the target A1C at the time of conception. However, then we have another set whom we call hyperglycemia in pregnancy. It could be pre-gestational diabetes. In other words, a woman who has conceived, but she did not know she had diabetes earlier.
Yes.
And a gestational diabetic. So so we need to differentiate between these categories and how do we approach them. So the pre-pregnancy planning will apply for a type 1 who knows she's diabetic, a type 2 who knows she's diabetic as well.
Yes.
Thank you very much. Dr. Shiva, could you tell us what is the psychosocial impact of diabetes?
Yes, ma'am. Actually, the psychosocial impact of diabetes is probably a neglected topic, especially when you are practicing in a busy clinic, especially in the government sector, where you see, like 200 to 300 patients in a session. So probably it's a neglected thing. And what we normally see is, especially in people who are not achieving any targets, probably they are failing to be compliant with their medication, or probably, they are not following your instructions, and probably like coming to clinic visit alone. You should always look for an underlying psychosocial problem the patient is facing. And it's mainly the communication. So the patients, to all those who are listening, I would like to say is probably, in a busy clinic, the doctor may not have time to ask, or probably address some of these psychosocial issues that you have. So probably patients, you as patients, to improve your care, you should try to speak to your caregiver, or probably not even the doctor, or probably the diabetic educator nurse, or even a health volunteer, or probably a diabetic, community worker who comes and visits you, to try to, communicate the problems. And if that is dealt, probably we can improve the care of the whole care of the diabetic patients. So I don't know about the other countries, this, this psychosocial impact, we probably are not concentrating much, and probably now we are, trying to improve it. And especially what we observed during this COVID pandemic, there were, like, because of this national-wide lockdowns, patients faced severe psychosocial impact that really, had a major role, or probably, deteriorated their glycemic control. So, as healthcare providers, we have to concentrate on this. And as patients too, they must try to speak, because it is the communication, the interaction with your healthcare provider, the interactive sessions that you have, when you come out with your problems, then the solutions can be provided. And certainly it will improve the holistic approach of the care that the doctor provides you. So for all those who are listening over there, psychosocial impact, and especially in our community, patients, they don't talk as the patients do in the Western world. They are, it's a one-to-one talk, and the patients, try to communicate. But here, our patients, they conceal everything, and they don't talk or probably reveal things unless you ask for or look for. So always, I think the patient-doctor communication is very important. And for patients over there, not only to the doctor, you can probably speak to the community nurse, the diabetic educator nurse, the community diabetic helpers, the health volunteers. And that will really improve the holistic approach of your care and the general, like management. It will play a major role. So I think we should, concentrate more on this psychosocial aspect of diabetes to improve the care of our patients.
Thank you. Thank you. So there is an actual entity called diabetes distress, so which needs to be attended to, and I think it is time taking. So we need help in that regard from the patient's perspective, and the doctor needs to spend time with the patient. Thank you, Dr. Shiva. Manoj, could you tell us about the use of telemedicine in diabetes?
So prior to April 20, teleconsultation was not allowed in India. It was illegal. I don't know about the other countries, but we were not allowed to do teleconsultation. So one of the good things that came out of COVID, besides all these webinars, is that we are allowed to teleconsult now. Patients can get to us through whatever way, and audio, video consults have become the thing of the day. I think it's a big boon, because now, even when things have opened up, patients, especially the younger ones, those who are comfortable with a video consult or an audio consult, they can keep in touch on time. There is nothing like, I didn't get your appointment, or I had to travel so far, or I was out of the city. Whichever part of the country you're sitting, it's absolutely legal and possible to do it teleconsultation. So there are, I think, a lot of plus points. Very few negative points to be kept in mind is, please treat teleconsultation as much carefully as you would do with a physical consultation, or even more, because you are more liable if something goes wrong. And don't take up patients who are acutely ill, very poor control of sugar. It's better to go physically to a doctor nearby, and then later on you can go to your doctor of choice for a teleconsultation. So all in all, I think it's a big boon. We should make use of technology, as we were talking even about data management. So these things can be put together if you have a good record keeping, which is something which is lacking in most clinics. And, it makes things probably better. And as we were talking about organ screening, we have a record that you had an annual eye checkup, a dental checkup. I don't know, sometimes that gets missed out, but dental checkup is very important. And the record for the urine albumin creatinine ratio, HbA1c, and lipid profile. So these minimum things, if you can keep in record, makes the outcome much better for our patients.
Thank you. What about WhatsApp consultations? No, that's a big...
So, no. So I have been doing WhatsApp video consultations.
Video consultations.
not the single line, what do I do now? What should I eat? Can I skip the tablet? I don't encourage my patients to do that.
I think that is what I wanted to bring out. That should not be encouraged as well, because it's likely to result in errors.
So yesterday I'm reading one line called curbside consultation. Just that little one-line thing. That is very dangerous.
My husband was a dermatologist, so he used to say that, see, they don't have an intensive care unit. So he used to call it a CCU, corridor consultation unit, because whenever anybody caught him in the corridor, they say, just, sir, please see this, I mean, it's with skin consultations, that invariably ends up. But I'm sure we cannot do that with like diabetes, like in a morning walk also sometimes, patient will try to corner you. You see, my sugar is this, what should I eat? Can I eat this? So I don't know about those consultations, whether they should be encouraged or not. So that was just in a lighter vein. Dr. Uruz, could you tell us about CGMS and the insulin pump? This is, how do we adapt to this technology? So CGMS is continuous glucose monitoring system, which Manoj had already alluded to in his discussion.
CGMS and insulin pumps, very advanced technology, requiring a lot of commitment by the patient, a lot of understanding by the patient as well as by the doctors. So, which I think is the reason that it is not being adopted that quickly being adopted here in our setups. CGMS, as you, madam, you just said, continuous glucose monitoring. It's a system in which a little device is placed on your body, so on arm or on tummy, and there is a receptor which is inside the skin or subcutaneous tissue, and it gathers measures the interstitial fluid glucose, and it gives you a continuous glucose measurement. So as the interstitial fluid glucose is 4 to 5 minutes lagging behind the capillary, so you need to recheck and collaborate the two levels. So multiple pricks are needed in it as well. It can tell you the sugar levels for the last 6 days. So you can see, it gives a graph, a beautiful, complicated, complex kind of a graph in which you can see the peaks and the depths. So when is the peak occurring, when is the dip? So, and then you discuss with the patient what was happening at that time, and then you can adjust the dosages. And this is usually given to the patients with type 1 diabetes and is also being recommended for patients with type 2 who are on insulin. So this is basically for those patients and those who have a lot of hypoglycemias or who have hyperglycemia and they are requiring, who are also having hyperglycemias. This device, these also has alarms in them. So you have it and they will pick up the low. You have to feed in the levels you want at which the alarm should go off. So at low levels, it will pick it up and it will give an alarm. So patient will know that he's going towards hypoglycemia. And it also has it for hyperglycemia. These CGMs then are also incorporated into the insulin pump. It is also called artificial pancreas. So these are gadgets which are of the size of mobile, a cell phone, and then they are again have tubings and they inject insulin, and the insulin which is used is regular insulin, and that's given continuously. So again, the problem is with them is their cost. They're very costly, and again the problem is how to use them is again a problem, but they help. Their help in hypoglycemias is very good. People who are having multiple episodes of hypoglycemia or are requiring multiple injections of the insulin. So this insulin pump or continuous insulin fusion system is CSII is very helpful in maintaining the levels in these patients. The insulin levels and maintaining the sugar levels, in these patients. So insulin pump and CGMs play a very important, and these are the future of the treatment, and however, they require a lot of understanding and a lot of education is needed for that. We have to, those who will take the insulin pumps, they will have to be taught about the carbohydrate counting and how much bolus they have to give and when they have to take it off. There can be issues with it. So if there is a problem with the needle, which is transmitting the insulin, then patient can go into decay. There can be faults with the tubing, with the setting, so patient can go into decay with it. So a very good thing, a very good device, but requiring a lot of effort on part of physician as well as on part of the patient. So, and very costly, $6,000 and per month cost for the replacement is almost $100. So very costly. I've not had any patient who has accepted it till now. In whole Pakistan, I know that there's only 4 or 5 patients all over Pakistan who have taken the pump. So very difficult for our population, I believe, but that's the future, I think. That's the future.
Thank you, Dr. Roos. So at least that awareness should be there, and there is something like that is available. Mm-hmm. And I mean, how the world is, like you're saying, progressing as far as diabetes management is concerned. Yes. So from just having a log where you're having a couple of readings like before and after meals, here you're talking of CGMS where you're continuously monitoring every 15 minutes, like Manoj said, and you for 14 days continuously monitor, you know, where the highs, where the lows, and then the management is much, much, much better. Maybe it's not perfect still, but it's magnified. The results are magnified. I think we've had a very, very good panel discussion. Thank you all. Mohan, could you do me the honors of asking? Do we have any questions from the audience?
Yes, ma'am. Yes, ma'am. Yes, ma'am. There are so many observations. I think everyone has appreciated the chemistry. It is the International Pathologist Day because I was just checking out Google Master. So there was a reminder that pathologists are also celebrating the International Day today. So congratulations to them as well. So one question has come regarding observation regarding COVID context hyperglycemia or new onset diabetes in the COVID scenario. So I think anyone who wants to really, maybe regional experience also, maybe this can be a message also, ma'am.
I think Manoj will take that question. Do we have Deepak and Ganesh and Shaila with us still? Jaminda?
Yes, ma'am. Yes, ma'am. Dr. Deepak is there. Dr. Ganesh sir is there.
Yes. Perfect. So maybe they can join in so that in whatever questions there are. Yeah, Manoj, would you like to take that?
Yes, I think COVID has, besides other things,
Thank you, Ganesh,
affected the control of diabetes on one side. And now beyond the lung and the heart, we have started talking of pancreatic involvement. So the new onset diabetes also is being seen with COVID. The question that remains in our mind is it a transient diabetes or it's going to become permanent diabetes? But all said and done, we have to be on our toes when it comes to management of diabetes. More often than not, you don't need to make any drastic changes in medication. It's only very occasional, especially the hospitalized patient, that they need to look into intensive management with insulin. But the bottom line is COVID has increased the number of new diabetics.
Absolutely. And if the patient is on steroids, like you say, obviously hospitalized patients on, I think, reasonably moderately heavy doses of steroids, then the sugars tend to go haywire. So that management is important. And like you said, pancreatic involvement and resultant. So I suppose the A1C would help us in that regard. So if your A1C, so that is the importance of what we've been trying to tell you. I think Shaila very nicely told us that the 3, like a 3-hour movie. So it gives you the 3 months. So if you've been diabetic earlier, then your A1C will be elevated. So that will tell us, will it go away after the COVID has been treated or not? So that's a very, very important point. Thank you so much, Manoj. What about any other question, Mohan?
No, ma'am, there was a few observations that madam is actually endeavoring to see the Dr. Uruj ma'am with the baby, and that itself conveys that she's a leader as such. So a family member who is so much supportive and joining us ESI SAFES in this program. So I think we should congratulate madam specifically. There is only 2 observations, ma'am. I think all these are good programs. That's what everyone is telling. So
I think we've had over 300
no more
logins.
questions.
And on other days, there have been a very, very good number of logins as well. So I think I would like to thank all the panelists here. But first, let me summarize. So what are the key messages? Number one, I think day one, like Dr. Shiva said, that check for complications at diagnosis. So the first thing that the patient needs to know that this is for life. Diabetes never goes into the past. I think in the first session, they were talking about reversal of diabetes. But even when we talk of reversal, the monitoring of the blood glucose values will have to be continued. You can't stop doing that. So even if you've actually reversed it, you need to continue to monitor. So the continuation or the continuum of monitoring in diabetes is very important. Whether we talk of blood glucose values, how we do it, whether we do it by simple glucometer or going to the lab, getting it done at frequent intervals, depending on the type of diabetes we have, depending on the type of medication we are on. So that is what is the whole concept of do it yourself. You should know what your targets are, because if we are trying to make everything patient-centered. So patient-centered means depending on your type, your associated comorbidities or complications, our targets change, our approach changes, how frequently you need to get tested. So blood glucose testing, screening for complications. Screening for complications, Shiva very nicely told you, it is the eye, the kidney, the nerves, then that is microvascular. Macro vessel is the big vessels, that is the coronary arteries, so the heart and the brain. So we are trying to prevent strokes and we are trying to prevent heart attacks from happening. Then look at the peripheral vessels. She nicely told you that the foot, the prevention of diabetic foot is extremely important, because once you get a little infection also, it's like wildfire. It spreads like wildfire. You can't go to work. You are confined. You can't walk. So your sugars go haywire. You have to be on insulin, antibiotics, so on and so forth. So that is extremely important. So the correct investigations at the correct time will save a lot of these complications. Then, of course, we've tried to tell you a little bit about the latest technology. What is continuous glucose monitoring system? Dr. Roos told you about what is the insulin pump and how it can be of value in the life of a diabetic. So I want to thank all the panelists again for being with us. Dr. Chaminda was very, very good moderator. Dr. Ganesh, Dr. Deepak Mal, Dr. Shaila Sheikh, Dr. Shiva, Dr. Manoj Chadha, Dr. Uruz Lalreman, and thank you. Thank you all for being with us today and being part of the panel. Mohan, thank you very much. You've been a great, great backbone behind all this. And of course, to Endocrine Society of India and SAFES for this important initiative. Thank you. Thank you very much. A very good night to all of you out there. Good night.
Thank you so much.
Thank you, ma'am. Thank you.
Thank
So
you,
tomorrow, just to remind everyone that tomorrow also we have another program. Yes, sir. Thank you. So tomorrow also we have another program lined up for you. The theme country today was Sri Lanka. So tomorrow we have theme country of Bangladesh. So from Bangladesh we have experts joining. So first panel will be regarding oral medicines, a friend indeed. And second panel focused on insulin. Insulin, as you know, is celebrating the 100 years anniversary. So Dr. Sujay Ghosh sir is there, Dr. Faria Afsana, so many of seniors, Dr. Ashur Ostogi, Dr. Nilakshi, and Dr. Sunetra Mondal will be the coordinator. So I bring you regards from ESI and SAFES, and I'm hoping that you have enjoyed our program. Please log in again tomorrow. Thank you. Stay safe. Together we can. Together we can.
Thank you.
All right. Take care, everyone. Thank you so much.